What we'll try to cover a little bit is which approaches we use, why we use them, and when we use them. So that's basically the outline for the next 30 to 45 minutes of this talk. So single approach is preferred, and that's what's done in the vast majority of cases. It would be a special circumstance where 2 incisions would be used. The 2 approaches that are the approach that we try to use most commonly would be a non-extensile exposure, which would be the Cochlear-Langenbeck or the ilioinguinal. And as you heard very nicely in the last talk, that there are times where an extensile exposure, such as the extended iliofemoral, is necessary. If we look at the instance of these and how often they're done, we can see from 2 large series, from Letournel and from Matta, that it's about 2 or 3% of the patients that will end up having 2 approaches done for fixation of a fracture. So it's an uncommon thing to do, but again, what we'll try to talk about is when we might do that. So which approaches do we use? Well, for the anterior approach, it's either the ilioinguinal or the iliofemoral approach, which is basically a modification of the Smith-Peterson approach to give us some visualization to the internal aspect of the innominate bone and down to about the iliopectineal eminence. The posterior approach that we use is our standard Cochlear-Langenbeck. These approaches can be done simultaneously in some instances, or they can be done sequential. If they're done sequentially, they can either be done as a planned procedure, or they could be done by addition of a second operative procedure and a second approach after you were unable to complete the reduction through the first planned exposure. So what are the theoretical advantages of 2 approaches? Well, in theory, it gives you it combines the access of each approach to give you a very wide exposure to the pelvis. Also, this can give you direct access to each column, so that does facilitate sometimes clamp placement, your reduction, and your ability to get good fixation after it's reduced. There have been some reports that it's less morbid than the extended iliofemoral approach or other approaches that you've heard, with maybe lower infection rates, maybe lower instance of heterotopic ossification, or at least similar, and even one report that had a lower nerve injury with this approach. It may allow us to use this in older patients to where we don't feel comfortable using an extended approach, or patients who have had embolization to their superior gluteal artery where there are some concerns about the vascularity to the abductor muscle mass when this has been taken out by the angiographer. Additionally, these are more familiar approaches. I think we're all very comfortable with the Cochlear-Langenbeck and iliofemoral or ilioinguinal approaches, but maybe less common with the extended approach. And it does facilitate treatment of concurrent fractures where we have an acetabulum and a pelvis at on the same patient. There certainly are some disadvantages, and when we think about it globally for the sequential approaches, it does give us a very limited visualization of the articular surface, only what we would be able to normally get through the Cochlear-Langenbeck or ilioinguinal, which is not very much. It also gives us a limited access to posterior columns that are complex, particularly those that involve the SI joint. And I just put this in because I think sometimes it's confusing when you say that to people, that you have limited access to the SI joint displacement, because we sometimes operate on the SI joint from an anterior approach. So this is just to show you a case. If you look at that middle slide at the top, you can see the injury that we're talking about. If you look at the 3Ds, the number 1 is basically what's intact, and number 2 is what we're trying to put back to it. And certainly you can see that on this other incision as well, but on this other 3D reconstruction. However, if you think what's there, the sacrum is right here and overlaps that. So you really can't see this fracture line from inside the pelvis. So if you go to the outside aspect of the pelvis, you have a nice visualization of this, and you can reconstruct the innominate bone to eventually get you back to the acetabulum, as we heard in the last talk. So that you can't do through 2 approaches. That requires an extended approach to be able to see that. Additionally, for simultaneous approaches, one surgeon can operate on both columns at the same time. He's either going back and forth, or it requires a second surgical team to be present, and that requires an experienced surgeon on both sides to make it work. And even with that, it's very difficult to work on both sides of the acetabulum at the same time without totally driving each other crazy and making it impossible to work. Sequential approaches or excuse me, the simultaneous approaches certainly have additional disadvantages in that the patient positioning requires the patient to be lateral, which can cause some difficulties, particularly with the access to the greater sciatic notch for clamp placement or for palpation with your finger. Gravity, as we heard Takeshi talk about in his talk earlier, can make it difficult for reduction. The ilioinguinal in the lateral position is very difficult to get to the medial or middle window. Through the iliofemoral approach, we have very limited access to the lower portions of the anterior column. Additionally, the floppy lateral position that's used for this approach, I think, is less than ideal, particularly for sterility. So the patient is positioned on a bean bag and basically is kind of rolled back and forth. And it's difficult for me to really imagine how this maintains a sterile field throughout the operative procedure doing that. The sequential approaches, if you do dual approaches, one following the other, does require repositioning normally. This requires a significant amount of time and probably increases blood loss that you would get from two separate approaches. Additionally, it's important to remember that the fixation you place through one approach can interfere with the fixation of the opposite. So this is a case in point where the anterior column is fixed first, and you can see this screw, which fortunately was recognized. But if it's not recognized, then it becomes a three-stage operation instead of a four-stage operation when you get to the back and realize that you cannot reduce the posterior column because you have a screw protruding through into it. So what are some of the indications to consider for simultaneous or for combined approaches? And we'll talk a little bit about simultaneous as well as sequential approaches. So for simultaneous approaches, I think it could be considered for the transtectal transverse fracture in a young patient, particularly the very high ones like you see here, where an anatomic reduction would be considered to be essential. This is actually a case that I did do that on early in my career to make sure that we got a perfect reduction on this patient. It does facilitate clamp replacement. It allows you to get direct access to the anterior and posterior column, particularly if there is some comminution along the pelvic brim, which might make clamp placement more difficult, and as well as judging the reduction from posteriorly. And it may allow you to avoid an extended approach in some of these patients. The reason that this has to be done simultaneously is because there's no break separating the anterior from the posterior column. So you can't do one column and then the other, obviously, because the ischiopubic segment is one piece. And if you can't reduce it from one side, you won't be able to reduce it from the other side either, probably. Sequential combined approaches are done in instances where we have a concurrent pelvic ring or an acetabular fracture together that might facilitate reduction of the pelvic ring along with the column of the acetabulum. Additionally, it's done when we attempt to do this a surgical procedure through one approach, but we are unsuccessful and then have to make a separate approach to the opposite column to complete the reduction. Instances where that might occur, where you would operate on one side and then not be able to get the reduction and go to the opposite, would include a T-shaped fracture. And again, these are fractures where there is a split between the anterior and posterior column. They're separate, so you can actually reduce one column, fix it, and then reposition the patient and go to the opposite side. That would include the T-shape, the anterior plus posterior hemitransverse, and the both column fractures are ones that might require this. Typically for a T-shaped fracture, most commonly, as we'll hear later in discussions tomorrow, but this would typically be a Coker-Langenbeck most commonly. If you're unable to reduce the anterior column from the posterior approach, then you can fix and reduce the posterior column. You may give it one or two more tries, but at some point you throw in the towel, you reposition the patient in a supine position and do an ilioinguinal exposure to complete the reduction. It's possible to kind of predict ahead of time things that might make this much more difficult for reduction, and the things that make a T-shape much more difficult to get reduced or the complicating factors would be a transtectal pattern, those that have an extended posterior wall associated with it, those that have an SI joint disruption or a symphyseal dislocation, or a wide displacement between the two two portions of the anterior and posterior column. So if these complicating factors are appreciated ahead of time, then you could consider an extended approach. You could consider planning sequential approaches, or you could even consider a simultaneous exposure. This is a case just to show, this is the multiple complicating factors. You can see that the SI joints are separated on both sides, rotationally unstable. The symphysis is separated in the front, and there's a wide separation between the stems of the T-shaped fracture. So this is one I think you could predict ahead of time is going to be a difficult one to reduce through one approach, and you could either plan extensile exposures or two incisions. The anterior columns and the anterior column posterior hemitransverse, or the both columns, again, are typically approached through an ilioinguinal, reduce and fix the anterior column, and then an intrapelvic reduction of the posterior column. If you're unable to accomplish this, then you would reduce and fix the anterior column and then reposition the patient to do a posterior staged Coker-Langenbeck. Again, just to remind you, the complicating factors for a both column fracture that might lead you ahead of time to recognize some difficulty would be your computer going completely dead. No, would be a complex posterior column, as we heard about before.
Eating for food.
Yeah, even the computer's tired, sorry. A wide displacement at the rim. Those that have an associated SI joint, or those with a small posterior wall, and I think, again, just to, if you see these ahead of time, then you could probably make a different plan ahead of time as opposed to addressing it at the end of the operation, having to do another procedure. Small posterior wall, I'll just remind you that usually the posterior wall fragments are with both columns are fairly large. They have a cephalad extension that comes up into the iliac wing and can be addressed from clamps placed around onto the outer aspect and then screws placed from inside to outside. But if the fragment is very small and still a critical fragment, then addressing this from inside like this is very difficult, and this might lead you to have to consider a second exposure to accomplish the reduction. Are there times where two incisions are preferable to an extended iliofemoral? And I think that probably the one instance or two instances would be those that are very low in the front but comminuted, or those, in other words, those with the anterior wall plus a posterior hemitransverse where the posterior column has significant displacement, or a T-shaped fracture where the anterior portion has some comminution. And I'll show you a case in point, and this is probably somewhere transitional between a T-shaped fracture with an extra fracture line in the front, or an anterior wall plus posterior hemitransverse with some displacement in the back, as you can see. So this one I think would be difficult to approach to an extended approach, and probably is one in my hands that's going to require two separate approaches, which is what was done. You can see the segmental portion to this anterior column here. So this was addressed initially from posterior with the Coker-Langenbeck approach, and then the patient was repositioned in the supine position and had an ilioinguinal exposure with reduction and fixation to the front of the pelvis. And then last, there always are special circumstances that might drive you to do something different, and this is a case I've treated simultaneous approaches probably once in the last 2 to 3 years, or 3 or 4 years, and this is a case in point. This is a patient with this fracture dislocation. It's a T-shaped fracture that also has this injury at the knee that was an open injury with the tibial tubercle and the capsular avulsions, and basically here are the 3D images to show you her T-shaped fracture. This is after closed reduction of the hip, and then to be able to repair the capsular disruption, it required at least some limited internal fixation through the open wounds without making additional incisions, and an external fixator. So positioning this patient in a prone position was not really possible with the external fixator, and the external fixator had no intention of coming off for the next weeks. So this patient was actually done in a lateral position, and Coker-Langenbeck with a small iliofemoral anterior just to help judge the reduction. It was helpful, I think, in this particular patient. So there may be times where you can't position a patient the way you'd like, and it might drive you to consider a second approach. So everybody take a deep breath because we're done. The summary: 2 approaches is rarely needed. It may be done sequentially or simultaneously. The most common indication is to complete the reduction of the other column when you're unable to be reduced to a single incision, and these include usually T-shaped fractures or both column fractures, and occasionally an anterior plus posterior hemitransverse. So thank you very much for your attention.